Thanks for joining me here on Point. We're going to be talking to Dr. Lisa Allen of Johns Hopkins Hospital in Baltimore, Maryland today. And she has a very, very nice bio that I want to present to you, and I want to do it right, so I'm going to be reading it. So that's why my eyes are going to be on the copy and not necessarily on the camera. Dr. Lisa Allen, PhD, joined Johns Hopkins Medicine and the Armstrong Institute in September of 2014 as the first Chief Patient Experience Officer for the system. Dr. Allen has oversight for improving the experience of patients and families throughout Johns Hopkins Medicine by coaching utilization of best practices, system collaboration, and culture exchange. She has over 30 years of experience in quality, safety, and patient experience leadership in a wide range of healthcare settings. She has many publications on these topics and presents frequently, both in the United States and internationally. She serves as an advisor to several organizations in the area of patient experience. Her team consists of coaches, patient relations, volunteer services, and guest services. She led the Johns Hopkins Hospital to be the first large academic medical center in the world to achieve gold certification for excellence in person-centered care by Planetree International. She has her PhD in medical anthropology and community medicine, a green belt in lean. She is a certified executive coach. Dr. Allen was named in the Becker's Hospital Review List as Women's Hospital and Health System Leaders to Know for 2015 through 2019, and a top 30 Chief Experience Officer in 2018 and 2020. So it's a great deal of pleasure to have Dr. Lisa Allen with me here today on Point. Well, thank you for joining us here on Point. I'm Ken Kiedrowski, and we have another one of those programs today. I'm thrilled that we can do this show today, having to do with the world of medicine, having to do with Johns Hopkins Hospital in Baltimore, Maryland. No matter where you are, you'll find something interesting here. Even though Johns Hopkins isn't your hospital, I'm sure there'll be some pearls of wisdom that you can look for at your local medical institution. With me, with us, is Dr. Lisa Allen, who is the Chief Patient Experience Officer for Johns Hopkins Medicine. So I guess, Lisa, the first thing we're going to say is, can you do a little bit of an explanation of what is the Chief Patient Experience Officer?
Sure. It's a bit of a hard role to define. There aren't a whole lot of us, but it is a role that probably came into about 10 years ago, maybe a little bit longer. And it's a role that brings patient experience to the table. I like to say I sit with the Chief Financial Officer, the Chief Operations Officer, the Chief Medical Officer, all the C-suite. And it really brings the patient voice and the concerns of the patient to that leadership table. We do things in our department, such as patient relations. We're the people who send you all those surveys. We also have volunteer services, the guest services at the front door, and we have a group of coaches that works with our nurses, doctors, medical teams, front desk staff around the importance of the patient experience.
This whole concept that we're talking about right now might be a little bit foreign to some of the older viewers here because well, I remember when I was a little guy and my general practitioner would come and visit the house. My mother and grandmother had to scurry around the house for a number of hours to make sure the house was just so, because this medical god was going to come and visit us. And we had to listen to everything he said because he knew everything, and you don't question him. Don't ask why, just say, yes, doctor, and, smile and, be glad he came to visit. So now this is a change. It's kind of like going back to the future where now, and I know all my doctors at Hopkins, they want to know how I feel. They want to know this. They want to know how my family feels about all this and that. So it's an old concept, but now it's a new concept.
Right. I think that there was, I remember those days. I remember when I had measles as a kid and the doctor coming to the house. But I think that what's really happened is that we've realized that you have to have an engaged patient and family to really have optimal health outcomes. So the movement started with patient and family-centered care. And some of the components of that are the respect for patients' values, their preferences, and their expressed needs, the coordination and integration of care, information, communication, and education, physical comfort, emotional support, and involvement of family and friends. And that's the area that really started looking at, how do we really bring patients and families into that office situation? So it's not what's wrong with you, but what matters to you. And this movement started many, many years ago, and they've really seen that by engaging patients and families in their care, you have much better outcomes. So I like to think about a time, there's this next component, which is really patient engagement, and that's patients deciding how best to fit care into their lives, and patients become involved in their care, and patients take action to get the greatest benefit from their care. So a great example is my mom, who was 80 years old at the time. She knew she needed a knee replacement. This was at a time when she was very social and had travel plans, and she knew what it would take to get through a successful knee replacement. So she told the doctor, I have a trip I need to take. I'll get back to you when I get back, and then we'll do that knee replacement. But she really was informed about what it took to get a knee replacement. So that's an activated, engaged patient. Very happy to say 7 years later, that knee is working fabulously, and she's still active.
87 now, if I did my math correctly?
Yes. That's correct.
God bless her. Excellent, excellent. Well, if I remember what I've learned, because I should disclose here that I am a volunteer at Johns Hopkins. I'm on a number of committees, including the Patient Family Advisory Council at Johns Hopkins Hospital downtown Baltimore. I know that one of the things you have to take into consideration, besides talking to the patient about what's going on inside, or what the perceptions are of the family, you also have to take in consideration as things like ethnicity, religious background, and things like that, because that can all come into play as to making a medical plan that's going to be specifically great for that particular patient.
Yeah, I think that's true. I mean, my training is as a medical anthropologist, and so really thinking about culture and the impact of culture. People can have a disease, but what we see is really their illness experience, and people express their illnesses differently. There are many cultures that are stoic, and so it's very hard to express pain or to be open. It doesn't mean that they're not in pain. So again, understanding the culture of where people are coming from and how they express their illness. Other cultures are very vocal around their pain. And so again, it's not that the pain is any different between one person and another potentially, but it's how they express it. What kind of a role they take when they're sick. Is it the oldest son that becomes the most important decision maker? Is it the wife, the husband? So it's all of these factors. And I think it's very complicated in healthcare, because really understanding family dynamics is important in looking at how the outcomes are going to be. And we really want positive health outcomes. That's what's so important.
And as a medical anthropologist, I don't know if this is true, but I'm going to make a guess that it's the males in every culture who feels the pain the most.
I won't go there.
Yeah, I know. I'll save you. But women go through childbirth
I will make no assumptions.
And do all that, and men go, what? Oh, I've got a sliver, sweetheart. Come over here and let's get this out. Anyway, moving on. So let's talk about. Let's talk about just and I think maybe you already covered them. Some of the key components to family and patient care.
Yeah, I think I have. I think, one of the things that has been affected a lot of us over the last almost a year and a half now, really, is what's changed in healthcare as we've been dealing with this virus, this pandemic, and really trying to keep everybody safe. A lot of what we had done prior had to change, and it had to change quickly. And I think we've all really been dealing with what is it, how do we do this differently? So if you think about some of the components of patient and family-centered care, the involvement of family and friends, we basically said, you can't come in. You can't come into our hospitals right now. We need to keep everybody safe. And so we became virtual. But virtual is very different than being there and having that opportunity to interact, 24/7. And prior to the pandemic, we were open 24/7. You could have a family or the friend that you wanted to be your care partner with you, and they could hear things and understand your disease progression, and they could understand what had to happen when you went home. So they were really partners in that care. We ended up telling people you can't come in right now. And so it really changed the whole dynamic. We used iPads and did Zoom calls and virtual visits. And so really the world has changed. And I think now what we're going to have to do is figure out what parts were good and what parts do we need to get back to where we were.
And it might be getting a little bit off topic, but during this time when the family members, especially there's a difference between people want to visit a patient and the real caregivers. Right. There's a real distinction there. And now I want to talk about the real caregivers who come in there and sit with the patient. If they can't come in, that just put extra pressure on the nursing staff and everybody else, because there are certain things that those caregivers could do to give a break, if you will, to the nursing staff.
That is so true. I think an interesting study just came out through the Barrel Institute in the Journal of Patient Experience. And what we found nationally is that fall rates really increased during the pandemic. Why would that be? Well, if you think about it, you have somebody in your room with you and you need to use the bathroom, and the nursing staff is busy giving medication or attending to other patients. Many patients just got up, and even though it wasn't safe, and then they had falls. If somebody had been in the room with you, you would have said, let me help you, or honey, hold it a little bit longer, let me go get somebody. And so I think a lot, at the beginning, the staff had a lot to give. I think as it wore on, the lack of having a care partner in the room really stressed the staff out. They had to be the emotional support. They had to arrange for the virtual visits. It put a lot of burden on very caring and compassionate people. Having somebody else in the room to hear, to help, to comfort, it's a huge part of how we heal as human beings, having that support. And again, I think your point is well taken, Ken. There's a difference between a casual visitor stopping in to see how you're doing and that care partner, that person you trust and rely on to help you through this very difficult time when you're sick. So I am so happy that rates are dropping and we're able to open up. We're not as open as we used to be, but we are moving in that direction. And again, having one care partner in the hospital or at the appointment at the ambulatory clinic is so critical. And again, we'd like to see ourselves open back up to where we were before, but it's going to take some time. And that's where I think vaccinations come in. The more people that get vaccinated, it opens it up to where you can stay overnight safely. It makes sure that the patient is safe, just makes society better. So I'm really watching those vaccination rates and hoping that everybody does their part to end this.
Well, I have both of my shots. I'm not going to pull my card out of my wallet to prove it to you, but I do. And I was never so happy to get the second shot. And I know there are people who are watching right now who are saying, "Oh, I don't want to get that thing." But I just folks, I don't understand why you feel that way. I just don't. I mean, I've lost a brother because of COVID. I've lost friends because of COVID. I've experienced how it hurts families and communities and what have you. How can you not have that shot or shots? Please think about it. Okay, enough said there. I'll stop I'll stop the
Well, I
homily.
will say
Okay.
I was so happy I was able to go meet my granddaughter for the first time. She was born right before the pandemic. I had my plans to fly across country, had to cancel that airline. So I got to see her not as a baby, but as a little toddler. So it's great joy to be able to travel again.
Oh, I understand what you mean because I'm a grandfather with 7 grandchildren, and this COVID has, well, this virus has really thrown the blocks into the lives of grandparents everywhere. So, getting back to the key here, and again, I think you've already started to talk about it. We've got to get back to it, and I guess the way we get back to this quote unquote normalcy is for people to get those shots because hospitals especially hospitals. I mean, people worry about going into the supermarket with or without a mask and all the box stores, but I mean, the temple of health, a hospital, you've got to be super concerned about the health of the people who are walking in, so they have to be vaccinated, they have to have those masks.
Yeah, no, it's so important. You think about that we have vulnerable people here. We have people undergoing cancer treatments, people who have gotten transplants, those immunocompromised patients, we really need to protect them. And so we still have, and you'll probably see this at any hospital that you go to, the need to mask. It's really to keep you safe and to keep everybody else safe. So many of our staff are vaccinated, but it's really, we don't know who isn't, and we don't know who hasn't achieved the full immunization that we need to have the immunity. So you need to wear the mask in a hospital. And we do ask that of care partners. Again, I know it's not comfortable, but if you're coming in to visit and to be with a loved one, then you need to be respectful of that and make sure that you're keeping everybody safe. And that's how we're going to open up more. We're going to open up more by having a high percentage of our population vaccinated and continuing to wear masks. And I think we'll see that even in the future. We're going to see that during flu season and other kinds of respiratory illnesses, it's going to be commonplace to ask people to screen at the front or screen at the clinic and then to mask. And I think with that culture, we're going to find that we're not spreading disease as much.
Well, my experience over last fall and this past winter was I'm wearing my mask and sometimes I'm wearing my shield. I went all the way out on this before I got vaccinated. And I noticed that, well, thank God I didn't get the virus. And oh yeah, by the way, I really didn't have as many colds. I didn't have the regular flu. I had one of the healthiest falls and winters that I've had in a long time. And why was that? Well, maybe I was using more antiseptic on my hands, but I was also wearing the mask when I went out into crowded areas. So there's a lot to be said about those masks. And all the big tough Americans who always made fun of people in foreign countries who would wear masks, well, they were right years ago. We should adopt wearing masks more often in our own society. It's not a sign of weakness.
I agree.
All right, now let me throw a word at you, and as soon as I say this word, you can talk for the next 15 minutes, I'm sure. Planetree. And there's a special designation that Planetree has bestowed upon Johns Hopkins, and maybe you could fill all that in for me, please.
Sure, so I can talk a little bit about that. Planetree is a organization, a nonprofit organization that was started, I think it was over 40 years ago now, by a patient who came from another country and got excellent clinical care in the United States, but felt that she did not get the kind of emotional care that she needed. And let me define for you how we see patient experience, because I think that it's an important definition, and Planetree looks at some of this. And what we say is that patient experience, I'm going to pull it up on the calendar. So patient experience is based partly on patients and families' high expectations of what's about to happen. And we know that patients and families, especially coming to a place like Johns Hopkins, have high expectations, and their cumulative evaluation of their journey through our system. And we have opportunities to delight or disappoint people based on their clinical and their emotional interactions with us. And let me just stop there for a second, because I think that's a piece why Planetree got started. Again, you can have great clinical interactions. In other words, you came in for something, and you know what? At the end, whatever you came in for was treated. But if you didn't feel that sense of compassion and empathy and care from those providers, you feel not the same. And I have had many discussions with providers around, you can be a great clinician, but if you don't show that you care, you haven't really healed people. And so that's where Planetree came from. And they have developed criteria that looks at involvement of family and friends, performance improvement around patient experience, involvement of patients and families, and having really active advisory councils like the one you're on, Ken, that really sit on our committees, that have a voice in the way that we develop our policies and our procedures. And so you go through a whole extensive set of criteria, and they come for a site visit, and they meet with patients and families, they meet with staff, they meet with our leadership. And if you meet the criteria, you can be certified at different levels. And I'm really proud to say that Johns Hopkins Hospital, the Johns Hopkins Hospital, was the first large academic urban institution to go through the Planetree criteria and achieve gold, which is their highest level of certification. And this was really a culmination of years of work by many different people throughout the organization to make Johns Hopkins a patient and family-centered organization. So it wasn't like we just took a checklist and said, well, let's do all of these things. This is years of work by so many people dedicated to the work around understanding the importance of patient and family-centered care. So we achieved that August of 2019. And, one of the things that we're going to be doing is relooking at that criteria, not only at the Johns Hopkins Hospital, but throughout our health system, and reassessing where are we? Where are we today with all that we've had to do to make it safer during the pandemic? And how do we get back to where we were? So the importance of education and patient-friendly types of education and involvement of care partners, all of those things we're going to be relooking at. And that brings me to another topic, which is really the patient experience surveys, that if any of you have gone to a healthcare system, I'm sure you've received a survey either through your email, via text, or on paper. And I do have people say, does it matter? Well, that data is what drives our improvement efforts. We read your comments, we share your comments. We even post some of the comments, for clinical practices about our physicians through our transparency project. So I think it's really important that we understand what are we doing well and where do we have opportunities to improve. And the voice of the patient, when you put those comments in there, or when we take it to our patient family advisory councils and say, help us be better, that's what really drives our improvement. That's what our coaches do at all of our sites to help work with the teams. They share the data, they talk about the comments, and then they develop performance improvement plans to make things better. And so it's always it's a journey. We plant seeds, we water them, we watch them grow. Some of them die, we have to go back and rewater, replant. But it's really a journey that we're on. And so this work is never finished.
Well, I know from my experience on the Patient Family Advisory Council at Hopkins is that there are so many different topics and projects that the PFAC has taken on. Three of them that I'll mention, and just to give people an idea of some of the things we can do to help make the life of patient and families better. And I'm not saying that I was the driving force behind any of these, but just to say there was the bills that come out of the business office. Mm-hmm. We worked with the billing office at Hopkins to try to make bills that were more user-friendly, if you will, that was easier for people to manage and to deal with. Because if you have a medical condition and you get a bill that you don't understand and you're pulling your hair out, that just makes the medical problem worse in some ways. So we worked on that and made improvements, and hopefully that made things better. Another project that I know you're very, very aware of, that the PFAC helped you with the wayfinding system, where people now can go into Hopkins downtown and they can take their friendly cell phone,
Mhm.
and just like when you go to Disney World, they have an app where you can find out if the teacups are spinning. Well, on the Wayfinder at Hopkins, you can find out where the cobblestone grill is, where you're gonna get your MRI, where you're gonna get the CT scan, where's this, where's that, where's the parking lot, how do I get back to my car, is my car still there, all those things. Oh, also how to find your way.
We can't tell you
down to
that.
Hopkins.
We can tell you where your car
Well,
is, not if it's still there.
We can tell you where the car is. We can tell you where the car is. And
Well, you
another
left
thing
it.
is we worked on menus. We're not dietitians, but we helped the dietitians to steer them into, and of course, there's the medical component of, too much salt, too much sugar, all those things that have to be taken into consideration for different types of medical problems. But I know that PFAC also worked on that. So there are a lot of things that lay people, if you will, can do to assist the medical staff into making a better medical situation for the patients and the families who come into Hopkins or any other hospital. I know one more thing that they did that might not sound important, but one of the things that came up was the establishment of a nice restaurant where people could get away. Patients and families can get away from the problems for a while and just sit there, take their time and eat and talk. And I know that that's probably not in existence at this exact moment because of that darn virus again. But as we get back, as Hopkins and other hospitals get back, things like that can get back into regular usage at the hospitals.
Yeah, so a good plug is certainly, please, if you are involved with a healthcare system, whether it's the Johns Hopkins Hospital or Johns Hopkins Medicine affiliates or any other hospital, look up patient and family advisory councils. We are always looking for members. We really need people. We really value your opinion. And if you don't have time for that and you get a survey, we ask that you fill it out because, again, we certainly do look at that. And it's important to us. And of course, my final plug is please get vaccinated. If you're not, it really makes a difference.
Well, you couldn't have said it better, and that's a good way to end our little discussion here. Dr. Lisa Allen, I can't tell you again how thrilled I am that you took the time to be with me here today and talking to the audience and also educating me in a couple of things here that I'm glad you did. So thank you so very much for being with me here on Point. Well, I would take another 30 minutes to review everything that we talked about this morning. So if there's something that you missed, then watch the show again, either on cable or go to YouTube and look at it there. Dr. Lisa Allen, certainly a fountain of knowledge when it comes to patient and family-related medicine at Johns Hopkins. But then again, what she's talking about is applicable to hospitals all over the United States and, in fact, all over the world. So here I am, Ken Kidrowski, thanking you so much for your time, thanking you for watching me here on Point.